Hello there, Namaste, Adab, Assalamu alaikum to all my friends in India and elsewhere in the world. After YouTube has been introduced into our lives, we have been so blessed to have so much availability of information. Through my YouTube video, I try to give you authenticated level 1 evidence-based information. However, you know that after few years in this critical care medicine field, which is ever evolving, this information which I am going to give you today will definitely become old by then and will require repetition. Nevertheless, I have again come up with new video on subarachnoid hemorrhage and few MCQs we are going to discuss, and we will discuss all the stems one by one, all the choices in in these MCQs. So that's the plan for today. Let's start.
Regarding the acute management of subarachnoid hemorrhage, so which options are correct or not correct, or true and false type of K type of MCQ? So the first choice is the peak incidence of vasospasm occurs at day 4. So we will examine it later. First, let's understand the subarachnoid hemorrhage. So a little bit of introduction. So aneurysmal subarachnoid hemorrhage is a neurological syndrome with complex systemic complications. The rupture of an intracranial aneurysm can lead to extravasation of arterial blood under high pressure into subarachnoid space and often into brain parenchyma and ventricles. Okay, so blood spreads out everywhere, and that causes tissue reaction, and that causes systemic uh, complex events which can ultimately result in widespread organ injury in brain. Apart from brain, it can result injury to the heart and can cause troponin elevation, ischemic complications, and in lungs it can cause ARDS. Kidney also it can cause injury, and also it can cause coagulation disturbances. So these all problems can occur systematically, and that is the reason we always take aneurysmal subarachnoid hemorrhage seriously. And all these complications are proportionally related to the most immediate problem is the rebleeding. So rebleeding is the most common and most immediate problem, which can be seen as sudden worsening of headache, vomiting, hypertension, and sometimes development of new neurological deficit, deterioration in GCS, or sometimes you will see in ECG there would be atrial fibrillation, new onset atrial fibrillation, or arrhythmia, or STT changes. It is seen in 1/3 of patients of SAH, and mostly in first 24 hours. That is the most dangerous time, and you need to monitor for the rebleeding, which carries a high mortality rate up to 50%. Okay, now what are the risk factors of rebleeding? So poorer is the grade on CT scan of SAH, that is Fisher's grading, modified Fisher's grading on CT scan. Higher the grade is, more will be the chances of rebleeding. Poor is the general condition of the patient, more will be the chances of rebleeding. Apart from that, hypertension and female sex are also risk factors for rebleeding, and that is the reason this hypertension has to be prevented. Blood pressure control is a significant component in the prevention of rebleeding. Now, apart from the rebleeding, another complication which can occur due to disturbance of flow or reabsorption of CSF is the hydrocephalus, which can develop in days to weeks. Okay, and it is the consequence of impaired reabsorption at the arachnoid villi, and blood gets clotted and it obstructs the CSF flow in the ventricular system. So that is the pathophysiology, and generally hydrocephalus presents as a gradual decline of sensorium, not as rebleed. It will be gradual. In rebleeding, it will be sudden, and usually hydrocephalus can be seen on CT scan very well as an enlargement of ventricular system. Okay, and the compression in the parenchyma. So these are the indications that the hydrocephalus is developing, and this is a kind of obstructive hydrocephalus, and it requires CVD placement. More commonly with the neurosurgeon, you have to discuss with them and get an AVD inserted. So vasospasm is the most common delayed complication and most feared complications also. Usually it is caused by the arterial wall thickening, vasoconstriction, and impaired dilatation. All these can reduce the cerebral blood flow. And if it is severe enough, ischemia and infarction can also occur. Okay, so that is why they say vasospasm, higher the chances or higher the severity of vasospasm, more will be the problem with the brain parenchyma. It will go into infarction, right? So most often, what is the timeline? Most often the vasospasm occurs 5 to 10 days after initial SAH and can persist till 3 weeks. And it also depends on the Fisher grading. Higher the grade of the SAH on CT scan, for example, the patient who is having IVH is at the highest risk of developing vasospasm and higher severity of vasospasm. Now, the first choice, the peak incidence of vasospasm occurs at day 4 is wrong. Actually, it starts from day 5 onwards. Now, another delayed complication is the hyponatremia, which can occur in up to 50% of cases, and it occurs between day 3 to day 14. Two most common reasons of hyponatremia are the SIADH and cerebral salt wasting. These are the two most common reasons, and both can cause hypotonic hyponatremia with high urine sodium. So you have to send this urinary sodium and you will find that the urinary sodium is high. So that is not going to differentiate SIADH from cerebral salt wasting. So what will you do is to find out the volume status. If SIADH is there, the volume status will be normal. It will be patient will be euvolemic. In case of cerebral salt wasting, so it is not just salt wasting, it is also water wasting. So patient will become hypovolemic. So in CSW, patient will be usually hypovolemic. And remember that SIADH and CSW both can coexist. Now, what will you do to avoid hyponatremia? So you have to be judicious with the fluid status, and fluid monitoring has to be performed very frequently. Avoid conivaptan, and you have to use fludrocortisone. You can use hypertonic saline to raise your sodium level. Now we will talk about the treatment. So what are the treatment available? So there are two types of treatments, uh, definitive treatment and the supportive management or supportive treatment, or you can say the preventive treatment. So what do we have definite treatment? So there are only two interventional or two treatments available as per international subarachnoid animal trial. We compared two types of treatment. One was the surgical clipping, another one was the coiling. Okay, though that is usually performed by the neurointerventional radiologist. And these two, clipping and coiling, were compared. And in the trial, ISAT trial, which was performed in 2002, and later it published 1 year and 5 year report, because all patients are followed up. And they found that at both time intervals, at 1 year and 5 years, the risk of death was lower in coiling group. Okay, but the functional outcome among survivors were not different at these timelines at 1 year and 5 years. So all these patients were followed till 10 years, and the findings were published later. So in this article in 2000, I think 15, this article was published again, and it showed that the disability-free survival was significantly higher with coiling compared to clipping. So coiling showed better neurological outcome at 10 years. Okay, but remember, these were the patients in whom rebleeding was more common. In coiling patients, the rebleeding was more common. Okay, that you need to remember, right? So clipping and coiling are not equally effective treatment options in terms of prolonged neurological outcome. So long-term neurological outcome is better with coiling. Now, after the aneurysm has been treated by either clipping or coiling, you have to induce the hypertension. So induced hypertension continues to be recommended for the management of delayed cerebral ischemia if it occurs. Okay, and it reduces the incidence of vasospasm and other complications and increases the cerebral perfusion pressure. So it seems an effective strategy for prevention of DCI related cerebral infarcts if it is not present at the time of onset. That is one strategy, and in which mean arterial pressure should be set more than 90 millimeter of mercury, or you can increase the MAP 10 to 20% above the baseline. So that will induce the hypertension and probably will improve the cerebral blood flow. Okay, so as this is the preventive strategy. So this option is correct. Now we will talk about the supportive management or preventive management, in which the fluid is very important. Earlier, triple H therapy of hypervolemia, hypertension, and hemorrhage was advocated. Multiple trials were performed in recent past, and they could not find any evidence for the use of triple H therapy. So you can say that triple H therapy is not at all recommended. However, there are some studies which advocate the use of induced hypertension, so that we continue to do. But definitely hemodilution have been abundant, okay, and it can cause reduction in the oxygen carrying capacity and reduces the CMRO2 and all. It induces the brain hypoxia. So stable euvolemia should be maintained with hyaluronic saline, and if patient develops cerebral salt wasting, you have to give large volume of fluid just to prevent the dehydration, that you need to remember. So hypervolemia, hypertension, and hemodilution therapy does not reduce the incidence of vasospasm. That is now old concept. Okay. Now what about BP control? BP control is vital to reduce the risk of rebleeding until intra-arterial aneurysm is secured, and during the first 24 to 48 hours post-operative period, you need to control the blood pressure. And generally accepted goal is to maintain the systolic blood pressure to less than 160 millimeter of mercury. Okay, for that you can use labetalol infusion and hydrolyzin boluses. These are the favored intermittent dosing medications. And if you are using, if you have a facility, you can also use nicardipine and clevidipine as continuous infusion. Now there are various studies coming up which advocate the use of nicardipine and clevidipine. Okay, regarding the nimodipine, nimodipine 60 milligram orally every 4 hours. That is the high dose. It is given for about 21 days for all aneurysmal SAH patients to prevent the vasospasm and improve the neurological outcome. Though no clear guidelines are available, but there is a consensus that it should be given for all these cases of SAH to prevent the DCI and vasospasm, and should not be completely. I mean, it should be given for 21 days. And regarding the intraventricular nimodipine, they say there is no use of using the intraventricular nimodipine, as has been shown by Newton trial. Okay, this was the Newton trial which showed no advantage of using intraventricular nimodipine, right? Now regarding the magnesium, magnesium is a vasodilator, a cerebral vasodilator. Sometimes they say that it is useful, and that has been tested in the trial, that is the MASH2 trial, and it's found that there is no improvement in outcome, okay, in the magnesium sulfate group compared to placebo. So magnesium sulfate is not at all recommended, right? That's all. I think we will move on to MCQ2 now. So this is also a true and false type of MCQ, K type of MCQ. So you are managing a patient with a World Federation of Neurosurgeons grade 3 subarachnoid hemorrhage post-coiling. So he developed a dense left-sided weakness. The neurosurgical team suspects vasospasm. Which of the following option is most likely to be of benefit? So these are the options, and we will discuss these options one by one. So regarding option A, intravenous high dose nifedipine. Actually, this is not advocated. Only oral high dose nifedipine is advocated. There has been a large systematic review and meta-analysis which showed no added advantage of using intravenous nimodipine. So this option is wrong. Now regarding option B, aggressive fluid loading. So this is again not recommended. It causes more problem of brain hypoxemia and infarctions. So it is unacceptable in brain injured patients. So we do not go for hypervolemia and hemodilution. Triple H therapy. Only induced hypertension is supported by latest evidence. So yes, we will go for induced hypertension as per latest evidence. And regarding the high dose atorvastatin, yes, statins have shown promise, but in recent meta-analysis, there is no significant benefit in the prevention and treatment of DCI if you are using atorvastatin. This option is also strike off. Now we'll move on to question number 3. So a 52-year-old female is admitted to the neuro ICU after a fall down 5 stairs. She did not lose consciousness but was confused over several hours after the fall. She is not intubated. A CT head was obtained and demonstrated SAH overlaying the cerebral cortex. So this is the CT scan, and you can see there are cortical hemorrhages, cortical SAH. Okay, or so which of the following is true about this patient? A. These SAH are caused by rupture of small superficial cortical vessels. She is at high risk of vasospasm. A catheter angiogram is to be obtained within the first 48 hours. Normal coagulation profile does not provide protection from traumatic SAH. Low risk of large arterial stroke is there. So we will examine each of these options one by one. So remember that trauma is the most common cause of subarachnoid hemorrhage. Trauma to head can be associated with small foci of cortical SAH, and usually these are caused by rupture of small superficial cortical vessels. So you remember that traumatic SAH is caused by the rupture of superficial cortical vessels. Okay. This is true that SAH are caused by rupture of small superficial vessels. Unlike aneurysmal SAH, the risk of clinically significant vasospasm is very low because the amount of blood which extravasates outside is also very low. So this is the wrong statement that she is at high risk of vasospasm. She is actually a low risk of vasospasm because the amount of blood is very less. Now, because she is at low risk of vasospasm, so CT angiogram is not at all indicated. Okay, in all traumatic SAH. Yes, in aneurysmal SAH they are indicated because there is arterial bleed, but in these cases, no. So this is the wrong option again. Now, patients with normal coagulation profiles can still have a small traumatic subarachnoid bleeds due to excessive shearing forces. So head trauma can cause bleeding in patients with the normal coagulation profile. So it does not provide protection. And mild trauma of this nature is not a risk factor for large arterial strokes, which we see in aneurysmal SAH. This is correct, low risk of large arterial stroke. So this is question number 4. It is a clinical question. A 47-year-old male was brought to emergency department with complaints of drop in consciousness followed by an episode of vomiting as per his roommate. A head CT showed a diffuse SAH with intraventricular extension, an early sign of hydrocephalus. A CT angiogram demonstrated a 6 millimeter fusiform aneurysm from distal right posterior inferior cerebellar artery. He was admitted to ICU. Later in ICU, same day, there was progressive deterioration in GCS, and an EVD was placed with an elevated opening pressure. EVD was clamped. Given the need to delay the definitive management of the aneurysm, TXA was started. Within 8 hours of admission, there was acute worsening of GCS further and acute increase in the ICP. And on opening of EVD, blood was visibly drained. What of the following is the most true of aneurysmal rebleed? Option A, rebleed more commonly occurs within the first 3 to 5 days. B, placement of an EVD increases the risk of rebleeding. C, posterior circulation aneurysm are more common to have re-rupture than anterior circulatory aneurysms. Or D, the use of TXA decreases the risk of rebleeding and improves clinical outcome. Or E, aneurysm rebleed does not change the functional outcome of those who survive. So this MCQ is very important not only for the candidate who are going to write exams, EDIC or NEET super specialty, but this is also very good MCQ for the practicing clinicians like me. So we will examine the validity of each fact. So the first one, the rebleed more commonly occurs within first 3 to 5 days. Actually, it occurs, okay. It is reported commonly to take place between 3 to 5 days following initial aneurysmal rupture. So this is the correct option. And now another option, the placement of EVD increases the risk of rebleeding. The correlation between the risk of rebleeding and the predictors such as poor clinical SCH grade or loss of consciousness or EVD or size of aneurysm has been debated. So rebleeding, the risk of rebleeding increases with, yes, the poorer grade, with the hypertension or female 6, but EVD is not associated with high risk of rebleeding. This is the wrong option. Posterior circulation aneurysms are more likely to rupture, but not more likely to de-rupture. Okay, so there is a difference. So remember that posterior circulation aneurysms are very commonly rupturing and bleeding and causing the SAH, but they are less likely to rupture compared to anterior circulatory aneurysms. This is the wrong option. TXA, that is tranexamic acid, has been evaluated in SAH patients and has shown to decrease the rate of early rebleeding. Okay, so this is the article, latest one, and this is a systematic review, and it shows that there is no improvement in the clinical outcome if you use the tranexamic acid. Okay, so this is the wrong statement again. Now the last one, the rebleeding causes change in the functional outcome or not. So yes, it can cause 60% higher chance of case fatality rate. So this is the article published in a stroke journal in 2015, and it is a very nice article. Everybody should read this, and it shows that the incidence of rebleeding leads to higher chances of mortality, higher chances of morbidity as well, and there is about 45 to 60% higher case fatality rate. Now we will move on to next question, question number 5. Again a clinical question, but it's very interesting. A 68-year-old male patient with past medical history of hypertension is admitted in critical care unit after a grade 3 subarachnoid hemorrhage was detected in ED, and CT angiogram showed an aneurysm of right MCA. 2 days after the initial bleed, while awaiting for surgical clipping, patient was noted to have drop in GCS to 8 and left-sided weakness. Transcranial Doppler showed and Lindegaard ratio of 2 was noted. Repeat CT shows hypodense fluid within the subarachnoid space and basocisterns and crescentric temporal horns of lateral ventricle. So his uh, serum sodium level is 130 millimole per liter. The most likely cause for his deterioration is A. Vasospasm, B. Rebleeding, C. Hydrocephalus, D. Hyponatremia, or E. Seizures. So remember that grade 3 is a very poor grade, which puts him at a high risk of complications, especially within first 72 hours. And 2 days later, patient develops drop in GCS in this case. So the new neurological deficit is there, which can be caused by any condition which is described in the choices here. But see, the Lindegaard ratio is 2. So what does that mean? So Lindegaard ratio is calculated by the mean velocity in the MCA divided by mean velocity of the blood in ICA. So this is how it is calculated. If it is more than 3, it is highly suggestive of vasospasm. You know, in case of vasospasm, the velocity of blood flow increases in the middle cerebral artery more than 3 times compared to ICA. So that is suggestive of vasospasm. Here the ratio is just 2, so it is not vasospasm, so vasospasm can be ruled out. Look at the CT findings. There is a hypodense fluid, means that there is a CSF, increased enlargement of basal cistern, crescentric temporal horns of lateral ventricles. Basically hydrocephalus is the answer here. Okay, so this is very clear cut. If you just highlight the CT finding here, yes, there is hydrocephalus. This is the answer. But what about hyponatremia? So hyponatremia of sodium of 130 does not cause profound symptomatology of this grade. So this can be completely ruled out. Yes, seizures are there, which are not uncommon. It can occur in up to 1 to 7%. But if CT could have been, I mean, in this case the CT was positive. If CT would have been negative, or it was not shown to a cause of iteration, the EG would have been performed to exclude a non-convulsive status epilepticus. So seizures, yes, could be a reason for these neurological changes, sudden changes in the neurological status. But if CT shows something, seizure may not be the number one reason. So most likely cause for his deterioration is hydrocephalus. Now this is the last MCQ and it is for you. Comment me which option is correct. So you just read carefully. You need to remember Hunt and Hess score and modified Fisher grade. So that is very important. So if you look at the ventricles, you can easily find out that what is your Fisher grade. Fisher grade is easier to remember. So I think I'm going to leave this MCQ for you to answer in the comment box. So that's all for today. Thank you for your attention. Bye bye. Follow me on YouTube and Instagram and ask your queries, whatever your clinical queries are, or if you want me to guide you for your career, I can do that. Okay, you can comment me personally. Also, you can comment on my Instagram handle. And best wishes for your future, your career, your life, everything. Bye bye. Take care.